Okay, so it's 12 p.m., so we'll make a start. Before we begin, I'd like to acknowledge the traditional owners of the land on which we're meeting. I pay my respects past and present to Aboriginal elders and Aboriginal elders of other communities who may be here today. So good afternoon, everyone. Thank you for joining this month's webinar titled Cleaner Air, Costs and Benefits. I'm Bill Dodd, the Centre for Safe Air's Knowledge Broker. Unfortunately, Dr. Sabrina Idrose is unwell today, so I'll be chairing today's webinar. So cleaner air arguably represents one of the most cost-effective ways of improving health, and even small improvements in air quality can have significant benefits at a population scale. Yet initiatives to reduce pollution and build community resilience to pollution events can be costly. Policymakers typically require a cost-benefit analysis and a health impact assessment before investing in cleaner air. In this webinar, we will learn about the costs and benefits of cleaner air, how they're estimated, how air pollution compares with other modifiable health risk factors, and how cost-benefit analysis can support evidence-based policy and practice. So I'm very grateful to our presenters today for sharing their research with us. So today's presentations will feature Professor Quentin Grafton, Dr. Edward Jegasothi, and Dr. Richard Broome. Each speaker will present for up to 15 minutes, followed by a Q&A after all the presentations have ended. So please drop your questions in the Q&A box that you can see at the bottom of your screen. Our first speaker is Quentin Grafton, who is Professor of Economics, Chairholder of UNESCO Chair in Water Economics and Transboundary Water Governance, and an Australian Laureate Fellow. He is a Fellow of the Academy of Social Sciences in Australia and a former President of the Australasian Agriculture and Resource Economics Society. He's included in the top 20 economists in Australia, as determined by the world's best economics and finance scientists, and is ranked in the top quintile of the top 100,000 world scientists of all disciplines. So thanks very much for being here, Quentin. Over to you. Feel free to share your slide. Yeah.
Thank you so much, Bill, and thank you everyone for joining us at this lunchtime. I also want to pay my respects to the Ngunnawal and Ngambri people, and I pay my respects to elders past and present. And I'm here in Canberra, the ACT. So what I'm going to do is give you a presentation in relation to the economic losses from long COVID. It'll be a short presentation, so there'll be plenty of opportunity, as Bill highlighted, for all of us for Q&A, including in the chat session. So what I'm attempting to do here is to really just go through some of the numbers in relation to long COVID, and I'll also start off with COVID, because of course you don't get long COVID unless you first had COVID. And then I will talk through some numbers from the UK, numbers in relation to Australia, and some numbers in relation to New Zealand, Aotearoa, New Zealand. So I'm going to start off with COVID and COVID-related deaths, just to give everyone a sense of where we come. I'm not making a prediction of where we're going, but certainly where we've come from. So if you look at what's happening here, so in 2022, we had about 6% of all Australian deaths were related to or reported to from COVID and COVID related. It dropped to around 3% in 2023 and dropped to around just over 2% in 2022. The point is that it hasn't disappeared. COVID is still present in the community. And if COVID is still present in the community, all else equal, we would expect that there will continue to be people coming down with long COVID. So this hasn't gone away. This hasn't disappeared. And although the numbers have declined in terms of COVID, and although the numbers would therefore have declined in terms of long COVID, additional new patients, nevertheless, it's still a problem that continues to exist in Australia and indeed pretty much everywhere in the world. So how do you work out what are the economic impacts of long COVID? So to be clear what I'm talking about with long COVID, we're talking about people who've come down with COVID, they've exhibited symptoms, and they haven't fully recovered. And how that fully recovered is defined in different ways by WHO and different researchers. But the bottom line from our perspective in terms of the economics is it's sufficiently bad enough in the context of long COVID and economic losses that it has an impact on their work, productivity. They may not be able to work, or work reduced hours, or reduce quality of work. And then, of course, the people who may need to care for them as well. There's a whole series of issues that go around that. So when we talk about long COVID and economic losses, typically we're looking at people who are having the more severe impacts in terms of their health. So how do we do this? Well, obviously you need to have a sense of how many people are affected by long COVID. Again, there's a substantial variation about what that number is. Certainly in a number of studies, and it could be much more than this, but in the number of studies that we've looked at, it seems that maybe around 3% of those people who are getting COVID are having long COVID of sufficiently severe symptoms that it has an economic impact in terms of their working life and ability to perform. So that doesn't mean that the proportion of people with long COVID is around 3%. It's just that they're sufficiently large enough in the impact on their symptoms to have an impact in terms of their economic performance and productivity. And the other presenters will be able to give you much more details around those proportions and how they may change. So if you look over to here, the most obvious effect, I suppose, for people to think about is healthcare costs. If you have got severe symptoms enough that you, for example, chronic fatigue is a common symptom, or brain fog, that's going to have impacts in terms of healthcare costs, and therefore increased budget expenditures in relation to healthcare. The other way, of course, it does it is if you're not able to work to the extent that you did previously, or work even if you work the same hours, you may not be able to perform at the same level. So that has impacts on your productivity as an individual worker and the people around you, because your productivity will affect the productivity of others. It also has an impact on your income. So if you're working fewer hours, that will have an impact ultimately on your income. And then that feeds into a macroeconomic impact, which is the sort of thing that I'll be talking about in the next few slides, which is called the gross domestic product, which is a measure of the value of the goods and services produced in an economy over a period of time. Typically, it's defined over an annual period, but it can be defined over a quarter. So you see, those are the begins with COVID, then it goes to long COVID, and then the long COVID sufferers, and to the extent they're sufficiently severe, there's a big enough impact here in the context of healthcare, workdays lost, productivity, income, and ultimately GDP. So this is a study from the United Kingdom from 2024, early last year, and it just looks at some of these measures in terms of long COVID. So you've got these different circles, and the circle in the black, which is indicating the negativity associated with long COVID in the economy. You can see that as a summary of the sort of impact that it is in terms of the working lives of people. You've got a loss of income, 1.3 billion pounds in that context, reduction in GDP of 1.5 billion pounds. This is on an annual basis. Reduction in household expenditures, which of course is related to reduction in household incomes. Expenditure is highly correlated with income. And then fewer jobs. So either you're not working, or you're having sufficiently enough impact on fellow workers that there are fewer jobs. This was a study done by Cambridge Economics, not by me, but to give you a sense that this is not just an Australian story. It is a story that exists in pretty much every country in the world. To the extent how big it is, it depends on the nature of the economy. And that's the demographics, but also the nature of the healthcare availability. It's this whole series of issues. But nevertheless, it's a substantial issue in all the countries that have looked at this issue. It's substantial. It's non-trivial. It's a substantial issue, as you can see with those sorts of numbers. And then, of course, as one would expect, there's an increase in healthcare costs, and there's an estimate there of approximately 3% of the increased health. This is from long COVID. Just because from long COVID, this is not from COVID, it's from long COVID. Of course, you have to get COVID to get long COVID, but that's worth highlighting. That's not just the COVID related, this is a long COVID related healthcare costs. So we, as myself, Long Chu and Tom Compass, we did some analyses with colleagues that was published in the Medical Journal of Australia last year. And we looked at the impacts on the Australian economy for 2022 in relation to long COVID. So our estimates here do not include the costs associated with COVID. If you include COVID, the numbers are substantially more. And of course, in 2022, that was the big year where we had a substantial number of deaths. 6% of total fatalities, deaths in Australia were related to COVID. So this is just long COVID, just to highlight. So what we have here on the first column on the left-hand side are the age groups. So these are age groups. The total is the total age groups from 10 to 64 years of age. Okay, that's the summary there, and the different cohorts or ages here. Now, what I've done is highlighted in red the cohorts that are most affected in the context of long COVID in terms of the size, in terms of the number of hours affected, and also the impact in terms of the proportion of the workforce. So you can see here, it's this middle age category, or young to middle age, so 20 to 50 years of age. That's where it's happening. So when we think about COVID, we tend to think of people who are vulnerable, obviously with health issues, but also people who are older. Certainly 65 plus, that's how we think about COVID. That's going to affect the vulnerable and the older people. You need to rethink that when you think about long COVID. So the proportion of people who are getting long COVID because a lot of people have got COVID is in fact in those larger age groups, larger cohorts, which are the working age cohorts. So when we talk about long COVID, it has a big impact on the working age population, and you can see that 20%, 27%, 24% for those age groups, 20 to 29, 30 to 39, and 40 to 49. And then you see on hours per employee, those are substantial. And of course, as you get older and older, the more and more people who are retired. So those are confidence intervals we have around that. And so we look at, in the context of long COVID, the inability to work in the workforce or temporary reduction in hours. And then that has an impact also for the other inputs that are used in terms of generating goods and services. So we can have two sets of numbers associated with the GDP, gross domestic product losses for the Australian economy in 2022. And so these two sets of numbers are the confidence intervals, if you will, around the numbers that we have. So a productivity loss only, so we don't consider impacts on any other inputs. And that's in the vicinity of $6 billion Australian. Or if you include the impact on other inputs, we're talking somewhere around $10 billion. So where does that land? That's about 0.5% of our gross domestic product in 2022 from long COVID only. If you add COVID in 2022, it's substantially more than that. So that's a big cost. To give you a sense of that, could have been equivalent of causing a recession. That's the size of these numbers. A 0.5% doesn't seem very much, but it is actually a big amount of money and has a big impact. And the other thing to keep in mind is this is 2022 only. Long COVID didn't disappear on the 31st of December 2022. It has continued in 2023, 2024, and 2025. As I showed you in the very first slide, people are continuing to get COVID even at a lower proportion. And so what does that mean? It means that long COVID continues to have an impact on the economy, not just in 2022, it continues in 2025. And so when you look at the benefit costs associated with doing something to reduce the incidence of long COVID, you were talking about reducing the incidence of COVID. Okay, and how can you do that? Well, one of the ways, obviously, with this set of presentations today is about improving indoor air quality. Okay, so there's a cost associated with that, either retrofitting in terms of better filtration units, in terms of public buildings, or indeed any building. And then there's this whole series of other measures that can be talked through as well. So what we did in our analysis for Australia, we took the next step and said, well, what are the costs associated with doing something in relation to improving indoor air quality? And what are the benefits? And the benefits, I think, are clear in terms of what we've just seen. The benefits are we avoid those costs in terms of productivity losses in labor. We avoid those economic costs, we avoid those higher healthcare costs, etc. And those are the benefits of improved air quality and the costs of, as I said, the retrofit, the filters, the et cetera. And so there's a big range here because we weren't clear about what the costs were. And obviously there were ranges associated with the avoided costs. These are the benefits from doing something. And we get some numbers from between 1.5 and 3.1. What does that mean? It's a benefit cost ratio. It means the benefits exceed the costs. And in the case of the 3.1, that's a big difference. And the benefit cost ratios of, more than one indicates it's a worthwhile investment. Certainly more than 2 and certainly more than 3, it indicates it's definitely a worthwhile investment. You can't normally get a rate of return in excess of 3 times what you've paid down. So those are big rates of return that are potential benefits to all Australians in some sense, if we're all taxpayers, as well as those, of course, who avoid getting long COVID. They are very big beneficiaries as well, of course. This sort of work has also been done in New Zealand. Again, this is not our work. The Australian work is our work, and so I can give you more details on that. In the New Zealand work, they looked at benefit cost ratios. And again, it's not too dissimilar to the sorts of numbers that we calculated. So you've got different benefit cost ratios, 3.4, 4.6. These depend on what benefits are you including or not including. Okay, so those are the sorts of numbers that we're getting from New Zealand. Again, high benefit cost ratios, and then you can see the increased productivity, reduced sickness, etc. And then these are the cited references, and happy to talk about it in the chat session, but very much appreciate the opportunity to talk to you all.
Excellent. Thank you so much, Quentin. Great presentation. So just a reminder again to make note of your questions. You can type them into the Q&A now if you like, and we'll come to them at the end of the presentations. So our next speaker is Dr. Richard Broome, who is a public health physician at the New South Wales Health Central Coast Local Health District. He was previously Director of Environmental Health at the New South Wales Ministry of Health and a member of nHealth. Since he began working in environmental health, Richard has played a leading role in developing and implementing life table methods for quantifying and valuing the mortality effects of air pollution. Over to you, Richard. Thank you very much.
Thanks, Bill. Thanks, Quentin. I'll just begin by paying my respects as well to Aboriginal elders past, present and emerging, and acknowledging that I'm on darkened young land here on the Central Coast. So look, I feel, so the title I've got for my talk is Cost Benefit Analysis, and I just fess up, I'm not an economist, so I hope you don't feel hard done by. But I, in my previous jobs at the Ministry of Health and through my role in nHealth, have been involved in various ways in the conduct of interpretation of cost benefit analysis. But my particular area of interest, I suppose, has always been in the quantifying of health impacts rather than their economic evaluation. But I guess beyond that, I've always been interested in how economists do take those values and try and place values on them. And in particular, some of the ethical implications of the way they're done, and particularly the ethical implications of using willingness to pay as the means of measuring the value of outcomes. So I'll be talking a bit more about that in a moment. And then I guess, because I'm not going to provide you with lots of numbers about, how air pollution is good for you and things. But what I would say is, having, seen quite a few CBAs of air pollution interventions done for governments in Australia, it's kind of almost invariably the case that they show that the benefits of action of reducing air pollution outweigh the costs, often by a large margin. We just saw one a moment ago by Quentin. I mean, that does seem to be the general theme, that it's very cost effective in reducing air pollution to improve health. So I'm not going to go into that anymore. But the second thing I'll say, though, is almost invariably in those cost benefit analyses, the major benefit that is seen, the thing that outweighs, or is essentially the social welfare that is produced by extending people's lives. And I'll just mention as well, just I guess because I have been someone who's worked in the government for these things, it's worth saying that it's not entirely clear always how the CBAs are used to influence decision making. So as I say, they almost invariably show that air pollution interventions are beneficial, and they go off into the cabinet process, and obviously other things happen there that lead to the final decisions, and I'm not really privy to those, but that's just an interesting phenomenon. So before I get into the details, I'm just going to say as well, so I'm going to assume that most of you are familiar with the general idea of what cost benefit analysis is. Basically, that it's a tool for evaluating policies or projects, and that both the costs and the benefits are measured in terms of money. And the fundamental aim of doing a cost benefit analysis is to try and find out whether a project generates an overall increase in well-being or welfare for the community. And you can do that in the CBA quite easily by subtracting the costs from the benefits. And if you have a positive number, it means that overall it produces a benefit. And then the final thing I'll just say before we get into it is that, again, I think most of us would agree that the idea when you're making a decision that it's a good idea to try and work out what the positive and negative consequences are, and to weigh those up in making the decisions. And that's the purpose of economic appraisal. So I think generally speaking, we'd all agree it was a good idea. And I guess what I want to focus on here is just a couple of issues that come up in the process of doing that people may not be aware of, that perhaps might make them think twice about some of the things that are said. So now I'm going to share my screen, if I can figure out how to do it. Okay. So I thought just before I get into the nitty-gritty of cost-benefit analysis, I'd mention cost-utility analysis, because for those of us that work in the healthcare system, I guess it's the general way that we operate here in the healthcare system in terms of allocating resources to different treatments and things like that. And it's useful to look at it because it provides a little bit of a contrast and focuses some of the issues in cost-benefit analysis. So the key thing with cost-utility analysis is that you measure the costs in dollars and the benefits in QALYs. And QALY is just a standardized measure of health, really, that takes into account both how much time you gain from an intervention and also the quality of life that you have for those that do gain. So an example might be a cancer treatment, which costs, say, $15,000 for each patient. And on average, the treatment might give a patient an extra half a QALY. So if that was the case, you'd say that the treatment produced a QALY for $30,000, essentially. But the thing that I guess I really want to point out here that's important is that when you make an assessment using QALYs of this sort of cost-utility analysis, you're assuming that a QALY has the same value for everybody. It doesn't matter who's getting the QALY. It could be a baby, it could be an old person, it could be a rich person, it could also be a poor person. It doesn't matter. A QALY is the same for everybody. And so I just want you to bear that in mind, because there's similarities with cost-benefit analyses, but which have different implications. So the main problem, I think cost-utility analysis is a very good thing, but the main problem with it is that it doesn't easily allow you to compare outcomes in different sectors of the economy. So, for example, it's hard to compare the benefits in QALYs from a healthcare intervention to the benefits from, say, an educational intervention, which is where I think one of the main motivations for cost-benefit analysis. So cost-benefit analysis puts everything into the same metric in terms of outcomes, so into the dollars. Dollars are the metric in which you measure the outcome as well as the inputs. And so that means, in theory at least, that you can compare directly interventions in different sectors of the economy, and that makes it easier to allocate money efficiently across the economy. So that's the kind of basic principle. But the thing I want to point out here in this slide as well, similar to the way a QALY is the same for everyone in cost-utility analysis, a dollar is the same for everybody in cost-benefit analysis.
Richard, you're not sharing, by the way.
I'm not sharing. Oh, I am sorry. Is that working now? So anyways, but you probably didn't need to see the slides. They're not beautiful.
Yeah, that's working now.
So
Thanks,
I'll just re-emphasize the main points of what I was just saying is that in cost-benefit analysis, the fundamental thing is that we assume that a dollar has the same value for everyone. And then in air pollution interventions, the key thing is that what we need to do is turn health outcomes such as extending lives or less asthma or whatever it might be into a dollar value. So that's what I'm going to talk to you about next. So how do we go about doing that? Well, economists use a process called willingness to pay, and essentially they try to work out how much individuals are willing to pay for the various inputs and outputs. And the important thing about what they're doing of that is that it's assumed that the amount that a person is willing to pay is a good measure of how much value they're getting from the thing, if that makes sense. So, so in theory, at least, if people are willing to pay more for a washing machine, for example, than a television, that's because they're getting more value from a washing machine than they are from a television. That's the kind of very broad idea. And then for things that are traded in markets, that's fairly straightforward. You can look at prices. That gives you a good indication of how much people are willing to pay for those things. Although it's obviously worth noting that people might be willing to pay a lot more than the market price. But when we come into air pollution and other sorts of health intervention, often things aren't traded. So for example, life or extending lives is not traded in markets. So there is no market price for that. So instead, economists do things called willingness to pay surveys, where they just directly ask people how much they might be willing to extend their lives, or typically what they will do is ask people how much they're willing to pay for a 1 in 10,000 reduction in the risk of mortality, for example. Or they might also, if another option is to look at how people actually behave in other sorts of markets. So for example, how much extra do you have to pay someone to take on a risky job? So those sorts of things can be used to get an indication of how much people are willing to pay. But unsurprisingly, what these surveys show is that willingness to pay is very closely related to your income. Essentially, the richer you are, the more you're going to be willing to pay for all kinds of things, including avoiding the risk of death. So essentially what that means, that if you use willingness to pay as the basis for estimating the value of a life, you come to the conclusion that rich people's lives are more valuable because they're willing to pay more. And similarly, that might lead you to conclude that an intervention that benefits the wealthy is going to provide more value than an intervention that benefits the poor. And so, that's a sort of fairly fundamental thing that's inbuilt into cost-benefit analysis, which is kind of, if you use it without considering that, you're going to start driving decision-making that will systematically divert our resources towards the wealthy. So I'm just going to give you an example of how this plays out in reality. So this is not a cost-benefit analysis, but it shows you how willingness to pay is used to estimate the costs of air pollution. So this is a World Bank report from a few years ago. And what they say is that the health damages of PM2.5 can be monetized to provide an estimate of the welfare costs of PM2.5. Now, they don't say exactly what they mean by welfare costs, but I think it's, in essence, what they're saying is it's an estimate of how much well-being overall is lost as a result of PM2.5. So what they then do is they use what's called a value of statistical life as the means of quantifying how much harm happens when someone dies, essentially. And we don't have values of statistical lives for every country in the world. So to estimate them, what they do is they got the VSL for the average value of statistical life for OECD countries, and then weighted them by the GDP. This top number here is the GDP of each individual country divided by the GDP of OECD, the average GDP of OECD countries. So essentially what that means is that if a country with a lower GDP will have a lower VSL, and vice versa. The higher your GDP, the higher your VSL. So you're systematically saying that the value of a statistical life is lower in poor countries and higher in rich countries. So that's how they essentially do their analysis. And then, so this is the kind of conclusion you get to, and I'll have to confess, I had to back calculate this a bit, so these numbers are a little bit rubbery. But I put here Italy and Kenya as two examples of countries with roughly similar deaths, just to try and make it a bit more obvious. But so this report says that there were 24,000 or nearly 25,000 deaths in Italy, with a total welfare cost of 100 billion, which equates to a welfare cost of about 4.4 million per person. And in Kenya, there are a similar number of deaths, slightly more, with a total lower welfare cost, as you would expect, given that they use a lower VSL, which ends up being as a welfare cost of about 300,000. So essentially what this is saying is that the life of a Kenyan is around about tenfold or more than tenfold less than the life of an Italian. And I say, just to be very clear, they're talking about the welfare cost here. So they're basically saying that saving the life of a Kenyan produces a lot less welfare than saving the life of an Italian. You can't get around, that's what the report says. Now, I'm sure, though, when we look at this, most of us probably think there's something a little awry, something's gone on wrong here, because and actually I'll just go back another step. So the implication of this is if you're someone who's wanting to introduce an air pollution intervention somewhere in the world, and you want to get the most bang for your buck, you would be wise, according to this report, to do it in a country like Italy, because you're going to gain more value than you would in Kenya. That is precisely what this report is saying. So, but as I say, so the issue here is most of us would agree that actually it's not at all true that the life of a Kenyan is any different to the life of an Italian in terms of value. It's a different life, but it's certainly not 10 times difference in the value of their life. So what's going on? So, and I alluded to this a little bit earlier, but the issue here is that the mistake, I guess, that's often made in cost-benefit analyses using willingness to pay is that it's assumed that the value has that money is of equal value to everybody. But that is manifestly not the case. A poor person, $1 to a poor person is worth a great deal more than $1 to a rich person. Simply, there's what we call diminishing marginal value or utility to money. So it's just not true to say that $1 is worth $1. So actually, when you do these cost-benefit analyses and you discover that an Italian, say, is willing to pay 10 times more to extend their lives than a Kenyan, it's probably a more reasonable assumption not to assume that the dollar is the same to them, but to perhaps that their life, the value of their life is the same, in which case what they're telling us is that money is 10 times less valuable if you're a Kenyan, if you're an Italian, I should say. To a Kenyan, money is a lot more valuable. So, so I guess why am I pointing this out? I guess, look, I'm pointing it out because I think there's a lot of these hidden sort of traps in cost-benefit analyses. And in my experience, when I've asked economists in government about these sorts of questions, they often just say, oh, well, it's just what the guidance says. This is just how we do it. And there's not much thought given to the underlying implications of what that might mean. And so one of the underlying implications of using cost-benefit analysis in this way, particularly in an international context, is it will potentially divert resources from the poor to the rich. And I will say that this is primarily an issue in these international cost-benefit analyses that get done, or even international research that gets done. I've seen it in quite a few papers. It's much less of a problem in local, and Quentin might be able to comment on this, but in what single country cost-benefit analyses, usually what happens is willingness to pay is averaged across the whole community. So you get a single figure for the whole country. And at least so in some ways, I think a lot of economists might say that might be an inefficient thing to do because you're not maximizing, you're not allocating resources in accordance with people's willingness to pay. And some economists believe that's what we should be doing. But on the other hand, it does make it much more equitable. So have I got much more time? I think I might have a couple more minutes. The only other thing, a similar kind of issue that arises as well is lives versus life years. So I'm just going to reflect. So very commonly in air pollution interventions, outcomes are reported in terms of lives, deaths avoided, essentially, as opposed to life years gained. Now, the issue with that is that different sorts of interventions may affect people of different ages. So, for example, a treatment for childhood leukemia saves the life of a child. A treatment for bowel cancer is much more likely to save the life of an older person. But if you valued all deaths equally, you would potentially value the interventions, an intervention that saves the life of a child, the same as you would value an intervention that saves the life of an old person or an elderly person. Despite the fact that the child might gain a great deal more life from it. Now, in health and in the healthcare sector, that's something that's very well recognized, which is part of the reason why cost utility analysis uses QALYs. But often it's very common in air pollution studies and cost benefit analyses and those sorts of things just to talk in terms of lives and then the value of statistical life, as I showed you in that World Bank report. And the issue with that, again, in a similar way to the way that using money as your metric for measuring well-being will lead you to divert resources from the poor to the wealthy, if you use, given that most people die at an older age, if you use deaths as your metric of value compared to life years, you will divert resources from the young to the old, which may not be what you want to do. So I think having gone into, hopefully there might be some questions about this. Mainly I hope this was a thought-provoking thing to just give you an idea that there's actually quite a lot of complexity in the background to some of these analyses, which is often glossed over in the high-level numbers, but it is very important to be aware of some of that complexity. Thank you.
Wonderful. Thank you, Richard, so much. And the questions are coming in, so thank you for your questions. We'll now hand over to Ed. So our last speaker is Dr. Edward Jegasothi, and Ed is a biostatistician and epidemiologist at the University of Sydney School of Public Health. He completed his PhD in 2020, which investigated environmental inequity with respect to the geographic distribution of the health burden of air pollution in the New South Wales Greater Metropolitan Region. Prior to his role as a lecturer, Ed worked at New South Wales Health, where he completed the biostatistics training program in 2018. For over a decade, Ed has worked with and for governments to assess health risk and impacts of environmental exposures, particularly with respect to air pollution. So great to have you here, Ed. Thank you very much.
Thanks, Bill. Thanks everyone for coming along today. It was great to be speaking alongside some distinguished experts. I'd like to acknowledge that I'm dialing in from the lands of the Gadigal people of the Eora Nation. I'd like to pay my respects to elders past and present. So I feel like we've got a good combination here of areas of focus for this seminar, and it's great that Richard gave a lot of that background and overview of the methods, because I'm not going into that, and also admit that I'm also not an economist. So I'm focusing more today on the issue of equity and the distribution of impacts, and trying to cast a bit of a critical eye over some of these approaches and the numbers that we get when we try to evaluate the costs and benefits of strategies to reduce air pollution and just measuring the impacts of air pollution more broadly. And you can see my slides, I hope. Okay. So we know that air pollution is a substantial contributor to the health burden globally and locally. We know that it is the cause of many adverse health outcomes, and a serious of which is the cause of premature mortality. At the same time, equity is a really important fundamental core principle of public health, and it's something that we ought to aspire to try and reduce inequality in the burden of disease and improve equity in terms of quality of life. And we recognize that there are inequities across lots of different dimensions of the air pollution burden. So we're thinking about exposure as well as underlying susceptibility to air pollution exposure. And so by inequity exposure, I mean that people who might be living close to roads or closer to industry, living in countries with higher levels of air pollution, might be also more susceptible to the impacts of air pollution by having being socioeconomically disadvantaged, and thereby also having underlying health conditions that make them more susceptible to the health effects of those higher exposures. And cost-benefit analyses are, as we've heard, can be a useful method in trying to think about how to convert the benefits of intervening to reduce these impacts, to reduce these exposures into economic impacts to justify their utility. So by combining the environmental modeling of the exposures, epidemiological evidence that tells us how much the health outcomes will change for that change in exposure, and then converting that to some sort of economic valuation, which then can be used to rationalize an intervention. These approaches are inherently focused on efficiency and cost efficiency. and are inherently utilitarian in the sense that they are distribution blind and not really thinking about how the benefits or the costs are distributed. It's looking at a broad brush approach of looking at the cost and benefits of an intervention. So what that means is these numbers produced at a large scale, a country or region or city level, can conceal inequities within and differences within and between populations. So these averages can mask not just differences but inequity, and so these leave critical. These approaches have these major gaps, including that which I just mentioned, and one Richard mentioned also with the issue of willingness to pay, potentially systematically undervaluing low-income communities. But as Richard mentions, it's largely to do at an international level, but there are issues even at a local scale as well. One thing that I want to try and leave you with in this talk is that an inequitable distribution of an exposure or the burden from an exposure does not mean that the intervention to reduce the exposure will be equitable, both either in terms of the costs or the benefits. And an example of that is in electric vehicle subsidies. So we might say that the air pollution is inequitably distributed across a city or a country. So therefore, it's an important thing to address for equity. But if the approach to reduce air pollution comes via subsidies, which are only really available to those who are socioeconomically advantaged, those benefits will not be equitably distributed. They might be there overall, but they're not going to be equitably distributed. So the costs, the benefits move up the socioeconomic gradient as well as the benefits. And the benefits have to come through a sort of trickle-down economic kind of approach rather than being directly equitable. So just because we see that a burden is inequitable doesn't mean that the strategy we take is equitable. Doesn't mean it's a bad strategy to take, even if it's inequitable. It just doesn't mean it is equitable. And one of the big challenges is there's a lot of missing context when it comes to cost-benefit analyses as well. A lot of the things that we have that cause air pollution have less tangible or less more diffuse benefits that can't really be captured in these cost-benefit analyses. So sometimes we only end up focusing on the things that we can actually measure and have robust evidence to estimate the impacts of. Another factor, and this is not specifically related to cost-benefit analyses, but burden of disease or excess impacts, excess burden of particular exposure or event. Like for example, COVID, when Quentin was talking about the loss of productivity or health loss due to the event, the counterfactual or the alternate scenario that they're comparing to is not having any. It's not the avoidable burden. It's what would have happened had COVID not existed. And now that's a really unrealistic scenario. And similarly with air pollution, we have the same kind of challenge. That while we can calculate this burden of, okay, what would have happened had COVID not ever happened, it doesn't mean that that's the amount of the cost that can be avoided if we intervene. It really depends on what the intervention is. And then we have to think about how those impacts and benefits are distributed. So that process doesn't include the cost of intervening, and remembering that assumption comparing those two scenarios, the reality compared with the scenario where that event did not happen at all, or those exposures were not present at all, requires an elimination approach which would have exponentially high costs to doing that. And again, those would likely be inequitably distributed. An example here is air pollution. And sorry for the messy graph. I'll work on something a bit more readable, but I'll try and talk you through it. This is looking at the each line represents a country, and the start of the line is in 1990, and the end of the line at the top of the arrow is or the end of the arrow is 2019. This is from the Global Burden of Disease study. It represents on the y-axis here life expectancy and air pollution on the x-axis, and the color of the lines is GDP per capita, so the relative, so the income level of that country. I've just made income static at just 2015, so it doesn't include any change in GDP. But what you can see from this is that countries that have low GDP tend to have higher air pollution. And I should note that the WHO guideline here is lower than any country actually has. And this is more or less the counterfactual, that alternate scenario from which we base this idea of 7 million deaths per year, if all countries had this level of air pollution. Now, as you can see, no country has actually achieved that. So it means every country has a burden. But it's important to remember here that the countries that have had the biggest improvements in life expectancy have not had an enormous improvement in air pollution. In fact, most of them haven't had any improvement in air quality according to these data over those 30 years. Those countries and the countries that have had most improvement in air quality were already rich countries that already had relatively high life expectancy. And they moved slightly across. So Australia's up in the top corner here, along with the Nordics, and highly developed economies, which are already very rich, already have transitioned to service economies, no longer manufacture as much. Those countries have lower pollution and high life expectancy. But the countries with the most improvement tend to have high air pollution. And that makes sense because the sources of air pollution are often tied to economic development. So, and with their health benefits. So countries that have improvement in infrastructure, in development, in employment opportunities, in trade, do end up having large benefits in life expectancy, large improvements in life expectancy in the absence of improvements in air quality. Not to say that we shouldn't, that air quality is not as big an issue. It is an important issue that needs to be addressed, and that we need to reduce air quality. It's still critical, but these estimates miss these massive trade-offs and the massive costs of elimination. And really importantly, it kind of exemplifies where the benefits and costs can be distributed, because if you expect that all countries should reach this level, what are those countries trading off? And which countries are trading off what to achieve those benefits? And this is from my PhD work. So it's a little bit dated, but hopefully it gives you a bit of a demonstration of some of this, how this plays out at a more local level. And what you can see on the left-hand side here is the concentration of air pollution. And don't worry too much about the numbers. Just think about the gradient. So each of these boxes represents a different sort of region. So this is all of New South Wales Greater Metropolitan Region, which includes Sydney, Newcastle, Illawarra, and the Central Coast. And each of these boxes represents a quintile of socioeconomic disadvantage by area. And as you can see, the concentration of particulate matter air pollution doesn't differ greatly by the socioeconomic status of the areas at the whole GMR, Greater Metropolitan Area. In Sydney, there is a bit of a gradient. In Newcastle, Illawarra, and Central Coast, there is also a little bit of a gradient, but altogether, nothing much is going on. But even then, the differences aren't big in terms of the distribution of air pollution. And these, of course, are broad area level, so it masks, again, disparities that might exist within an area where people live closer to roads or closer to particular industrial sources. Now, on the right-hand side, this is an estimate of the burden of disease attributable to those exposures and comparing them across those different quintiles. So the gradient here, so each of these is a ratio. So again, don't worry too much about the numbers, but just look at the shape of those graphs where you see that as you could move across from most disadvantaged to least disadvantaged, the burden due to air pollution decreases. Here we've got all of the Greater Metropolitan Region. On top row, I've got mortality, so we can just focus in on here if you'd like. And this is years of life lost, where we're using Richard's method. This is something that Richard and I collaborated on at the time. And you can see that the red lines are the baseline rates of mortality or health outcomes, depending on what row it is. And the blue bars are the rates, are the burden of air pollution. Now, you can see that the gradients actually match up pretty much identically for most outcomes, whereby the gradient of the burden of disease of air pollution just is basically just the burden of is the underlying baseline rates. And that makes sense because we don't have a huge gradient of the air pollution. It's mainly driven by the underlying health risk. So even with almost identical air pollution exposure, we have a gradient of burden of disease because of not the exposure, but because of the underlying health risk and assumptions of the burden of assumption of the underlying rates of mortality, of life expectancy, of health outcomes. Now, this is not unique to air pollution. This is from the Australian Burden of Disease study. Every risk factor that you estimate will have this pattern because the rates of disease and rates of mortality and years of life lost follow the same pattern. So when you calculate the attributable number of DALYs or years of life lost, it's always going to follow this pattern. Now, so then if you were to say, oh, well, it's an equity issue because there's a greater burden, you could say that about literally any risk factor. But that doesn't mean that you can address each of these risk factors independently. What it does lead you to, what it should lead you to conclude is that we should be looking further upstream, in addition to looking at those things independently. So looking at air pollution, looking at all those different risk factors, but also thinking about how do we address the upstream root cause of the socioeconomic disadvantage, the disadvantage itself. So, and this is where we can think about what is the pathway for having this higher health burden. The health burden the distribution in the health burden, that social gradient in the health burden, where people who are more disadvantaged have a higher health burden, comes from higher exposure to air pollution, higher vulnerability to the exposure, and reduced capacity to mitigate the exposure and the impacts. But that's all due to the disadvantage itself. So when addressing all of these factors which lead to the higher burden, we can be thinking about how do we address income and wealth inequality? How do we address inequality in housing, affordability and conditions? How do we improve equality in working conditions and urban planning? And in the context of doing evaluation of interventions, we can include these objectives of equity in the modelling itself. We can think about distributional cost-benefit analysis, actually explicitly disaggregating the costs and benefits to say who benefits and who is harmed. Look at that. We can go geographically, look at that with area level socioeconomic indices from the ABS. We can look at that using individual level data if it's available. We can incorporate that into our health impact assessment when we're doing, so that can be cost-benefit analysis when we're deciding what to do, what's the right thing to invest in. We can do that when we're assessing what the project itself that's being proposed. And when we're doing a health impact assessment that has an equity focus, that actually considers and has explicit objectives to narrow gaps in exposures, in vulnerability, by assessing the impact, the cost and benefits in a disaggregated manner, but also including less tangible social impacts. And really importantly, really talking to people, understanding what it is they value. Because those, as we talked about, values are going to differ across populations and between populations. It's so important to be able to talk to those communities and understand what they think is important for their health overall, to determine how to value different health risk factors. And potentially also to deal with the willingness to pay, equity weighting strategies that might compensate for that disproportionality in willingness to pay based on income. Lastly, I'll just leave you with this issue of the limits of modeling. So one of the things is a lot of these processes are really reliant on multiple stages of modeling. So we've got modeling of exposure and the scenarios of a new intervention. We've got the epidemiological modeling, which determines the exposure response function or how much the health outcome changes. And then we have the economic value as well. And often these are really imprecise. They change over time, like Quentin was talking about with COVID, where these measures might not still be valid with changes in demographics and changes in immunity, and might not be. And these this kind of imprecision gets multiplied across those different levels. And one of the real challenges is when we're talking about things that are going to be having huge government investment, there are lots of ways of manipulating this kind of evidence, because these numbers can be quite sensitive to those assumptions, which means that when there are interests in either overstating or understating those numbers, those can come through in terms of how the numbers are produced. And it's really important to remain critical of the measures. So finally, just to conclude, reducing health risk is critical, but we need to be using these tools critically, and because cost-benefit analyses are inherently blunt, it's important to reduce inequity. We must be deliberate in actually trying to reduce inequity, and the approaches should prioritize the distribution in terms of reduction in exposure and vulnerability, and also be accountable for doing so. And let me just finally this quote with not particularly religious, but it's with the passing of Pope Francis. Here's a quote from him: that we are faced not with two separate crises, one environmental and the other social, but rather one complex crisis, which is both social and environmental. Thanks.
Thanks very much, Ed. Really interesting thoughts, and we'll go now to a bit of a Q&A and discussion. Before we do, I just wonder if we could throw to our expert economist, Quentin, just for some reflections on some of the ideas brought up there around the willingness to pay issues in some of those assessments, or the counterfactual scenarios. And
yeah, I mean, both Ed and Richard made some really good points. That there are ways to respond to them. So, and they have been, and they do exist in the literature. So, what may be happening in the Department of Health in a particular state in Australia may not actually be true in the context of economists publishing in the academic literature. So there may be a divergence there. So for example, we did a study in 2020 in relation to COVID in a value of a statistical life year, and you took into account life expectancy. So that had some adjustment to account for the amount of years expected for the people who are suffering from mortality. There are adjustments that can be made to account for those sorts of issues. Willingness to pay is problematic in the context of what Richard pointed out. On the other hand, there was also a problem with COVID in 2020, when people were saying, well, you're no longer in the workforce, therefore you are valueless. That was sort of the other extreme. So since you're not working and not productive, then your life is worth zero. And there are commentators in Australia and elsewhere making those points, which are, is clearly false. So that's another point. The other around, willingness to pay, and it's really about ability to pay. And that's why we're getting these differences, and it's certainly it's well known in the literature, and although that it's not done as it should be done, that's a problem. One way to do that, and for example, in climate change costs, you can do percentages of GDP. So what you find is if you do projections out to 2050 or 2100, you find that the countries that are suffering the biggest percentage losses are in fact the low-income countries, and very large percentage losses. If you did it simply on values, because they have typically low GDPs, you wouldn't get the same distributional impacts in either visually or in a quantitative sense. Yeah, and then finally, the point that Ed made, distributional weights can be used and are used in benefit cost analysis. I do recommend they be used, but they need to be done very transparently, because using distributional weights in an obscure or opaque way can lead to a whole series of results that can be fixed and fiddled with. So that's a problem. But I certainly think the issues around winners and losers, what the distributional losses, gains, are extremely important and are critical in terms of good decision making.
Great, thanks, Quentin. We've had a number of questions here where I might circulate some responses by email to people who've registered later if we can't get to them all. But I'll just ask this one from Ben Ewald around just as the SVL, I'll need someone to help me with that acronym, reduces the value of a life in a poorer country, the use of discounting reduces the value of benefits for people in the future. While the discounting of future benefits is standard economic practice, when applied over long periods, it reduces current value of future benefits to close to zero. This contradicts the sustainability principle that future generations should have as good environmental conditions as current generations. Is there a way around this problem?
Yeah, well, you can do zero discounting, and there's other ways you can discount as well. Hypergeometric. There's various ways of doing that. Discounting makes sense in a financial decision making because the returns or costs coming in at different times makes perfect sense. But when we start to deal with matters of a massive global context, climate change, pandemic, whatever, certainly climate change over many decades, it doesn't make a lot of sense. Even discount rates of 3 or 4% means that a century time, the benefits from doing something today, mitigation, are very small. And that doesn't make any sense for the reasons that was outlined in that question. Sorry for interrupting, but yeah. So there again, the literature does allow you to think this through. A whole array of ways of thinking about social rates of time preference, but often that's not the way it's done and thought through in the way it needs to be done in the work that I often read.
Wonderful.
Can I just add
Yes,
there?
please,
Sorry,
Richard.
I feel bad coming off because obviously Quentin knows much more about this than I do. But so obviously that issue with climate change, that was the whole debate. The Stern report in the UK, which recommended a very low discount rate for future benefits in the long-term future, obviously was very controversial, it seems, internationally. But the other thing I just wanted to mention, I suppose, is I think generally speaking, the idea of discounting is not a bad one, is it? I mean, the idea is that things are, because we have more stuff in the future, each additional unit of stuff is less valuable to us. But that may not apply to things like life and well-being and all those sorts of things. And so, and that often seems to get missed out. So, the UK Green Book is actually quite good on this, I think. So it specifically says if you're, for discounting of life years in the future, for example, you should, I can't quite remember what the value is, but you knock a couple of % off your discount rate because essentially a life doesn't matter when a life is, it's just as good. That's the kind of principle, I think.
Great. Thanks, Richard. Well, thank you all. That's been a really very full discussion, and I apologize if we haven't gotten to your question today. I'll send a follow-up along with the recording of today's presentation. But huge thanks to Richard, Ed, and Quentin for their great presentations and thoughts today. So yes, we might wrap up today, and we'll see you all again next month. But thanks very much.
Thank you. Thanks, everybody.